Thank you so much for joining us tonight for this webinar series brought to you by the Digest Institute at Cornell. As you guys all saw on the invitation, today we're going to be talking about functional upper GI symptoms and get you some expert perspectives on that. So my name is Dr. Ashok. We have three amazing, very experienced panelists today. We have Dr. Cohen, Dr. Mulvihill, and Dr. Sumac, all of whom are very experienced in treating functional upper GI issues. Before we go any further, though, we have to state a disclaimer, right? The purpose of this webinar is informational and educational. This is not specifically intended to give people individual medical advice. And we're going to be answering questions throughout this webinar, but we're going to integrate them primarily into the webinar itself. So if there are very specific questions that are really only applicable to individual circumstances, we'll reserve those types of discussions for the clinic. Um, and then just because I think it's always nice to set a frame for what we're talking about. And this is, one of my favorite statisticians. Altman, he basically sort of coined a lot of the statistics around precision medicine. Anyways, the point here and the sort of overarching message with a lot of what we're going to be discussing today is that you know, not everything in medicine can be tested positive for. And I think that's really important to keep in mind when we talk about some of these issues where, medicine just hasn't necessarily caught up to being able to, diagnose these as well as one might with, a blood infection, for example. All right. So, just to do some agenda setting today, we'll be talking about functional upper GI issues. But first, we'll talk about like what exactly is a functional upper GI issue. We'll talk a little bit about how common they are. We'll address how we evaluate it, and we'll also talk about different treatments. And as with everything, we like to ground things in our patients, right? So we'll start off with a patient scenario. I've underlined, sort of the main things here, but in some, we have the 63-year-old woman recently lost her job, and for the past 6 months, she's been having upper abdominal pain. She describes it as being right in the middle, sort of her upper abdomen, and describes the pain as dull, throbbing, doesn't matter what she eats or if she's even eating at all, actually. Comes and goes, this pain. And she also describes feeling, just full right after her meal, not being able to eat as much as she used to. And then also some difficulty swallowing. Now, this isn't like frank difficulty swallowing where things get stuck, but the food goes down and it just doesn't feel right when it's going down. She hasn't had any vomiting, hasn't had any weight loss. And as I mentioned, no frank difficulty swallowing in terms of things getting stuck, and hasn't had any bloody stools. She used to be very, very active. Hasn't been able to keep up with this routine though, since these symptoms came on. Never smoked, only drinks socially. Has been taking medication to help with anxiety since she was a teenager, and the dose has been stable for that. Her physical exam is normal, but she does have a little bit of pain and flinches when her upper abdomen is pressed. No trauma recently, no car accidents, no change in her medications, and it's important to note, right, given her age, that she is also up to date on her colonoscopy. So, starting off with what exactly is a functional upper GI issue? Dr. Sumek, if you don't mind chatting a little bit about it.
Sure, thank you. So, just starting from the top, an upper GI issue, we're talking about either the esophagus or stomach, maybe the first part of the small intestine, which is pretty long. And someone who has symptoms related to those organs, we think about infectious diseases, inflammatory diseases, precancerous issues, cancerous issues, physical blockages, et cetera, et cetera. And if we're able to rule out all of those types of things, then we're talking about a functional upper GI issue, meaning that the person has symptoms related to those organs, but that the tissues themselves, in every way that we test them, look very normal. And that we'll talk about why that may be in a second, but it sort of requires symptoms like upper abdominal pain, which is one of the more common upper GI symptoms, early satiety, like this patient is describing, feeling full faster than usual, not being able to eat a big meal. Postprandial fullness, again, is a similar idea, feeling full fast and not being able to finish meals a person maybe used to be able to finish, and nausea. Other symptoms, like this patient described, could be issues related to swallowing, or even symptoms like heartburn. Um, Functional GI disorders in general, including functional upper GI diseases, are called disorders of the gut-brain interaction. So the GI tract has a brain of its own. So there is an entire nervous system dedicated to the GI tract, which is why someone who has their spine severed completely, so someone who's a paraplegic, will still have GI function. You don't need your brain and spine attached to your GI tract for it to work, but they are attached. And so the GI tract has its own brain to sense things, to move things, to secrete fluids, but it is connected to the brain. And so either of those two nervous systems can malfunction, and they can malfunction in a way that can change how the person senses things. So that person can have a completely normal looking GI tract, but they are constantly having symptoms because the nervous system, which we can't really test for, we can't biopsy the nervous system, isn't functioning well. And because of the connection to the brain, because those two nervous systems are connected, issues that affect the brain will affect the gut. So things like depression, anxiety, mental trauma, post-traumatic stress disorder, stress, lack of sleep, et cetera, et cetera. All of those things will interact with someone, with someone's GI tract, and possibly manifest the symptoms, or more commonly, will exacerbate symptoms that are happening within their GI tract.
Awesome. And, I think one of the things that Dr. Sumac beautifully described just now was the interaction between sort of these two sides of your nervous system. I think a lot of people, when they hear about functional upper GI issue, there's a common misconception that, for lack of a better phrase, colloquially, people think it's in their head, right? And that's really not what the case is here. It's just that the science has not advanced to the point where we can really easily test for this stuff, right? Because as Dr. Sumac, mentioned, we don't go taking biopsies of people's nerves, right? That would not be ethical. And so, Dr. Cohen, I'm hoping you could sort of elaborate a little bit on the how common these things are.
Sure. They are super common. They're one of the most common things we see in our offices, and a lot of people don't even come and they're probably experiencing it. It Functional GI disorders range from the top to the bottom, so the esophagus, the stomach, the small bowel, and the colon. So it can be anywhere in the GI tract, and it affects approximately 40% of people worldwide. That's a huge amount of people, and it can impact their ability to go to work, go to school, go out to dinner. It can really impact people's quality of life. These functional GI disorders, they're not necessarily going to impact morbidity and mortality, but it really can affect how someone functions, and we want to help them. And there's, like Dr. Shook said, we don't have tests for them, to definitively do this, but when we know it in this world, and once we can get you a diagnosis, there's so many options. So the cost of this, because it impacts so many different aspects of people's lives, is approximately in the US $18 billion annually. So that's a lot of money. So that's time of healthcare, that's lost time of work, that's lost time of school. So it's really impactful. So similar to what Dr. Sumek said and Dr. Shook said, people always say it's in your brain. It's not. It's based in a disorder of miscommunication between the brain and the gut, but the symptoms are real and it affects people. So the goal is to find treatments for people so we can move them back into what they want to do.
That was beautifully said, Dr. Cohen. I think especially sort of articulating that um, these are these can be devastating to people's lives. And, sometimes we'll hear people come into clinic, I shouldn't say sometimes, very frequently, and they'll say something along the lines of, uh, I know people think it's not that serious, but it's completely devastated my life. And so a lot of these issues people end up minimizing or not even seeking care for oftentimes. Okay, so let's go back to our patient. And let's chat a little bit about what exactly we would think about and how we would approach her when we met her in the clinic. So here, Dr. Cohen and Dr. Mulvihill, I'm hoping you could sort of elaborate on what things these symptoms bring to mind and what kind of tests you'd want to do.
Do you want to go first? You want me to go first?
Um, I, you can go first.
Okay, sure. Hi, everyone, Zach. So, first a word in the functional disorders things. It's a tricky thing, just to echo what people were saying. Just because something doesn't show up in a blood test, doesn't show up in a CAT scan, doesn't mean it's not real. And actually, in my clinic, so it's kind of an integrative clinic. So we do a mix of Western with functional and some Eastern medicine. We deal with these types of disorders all the time. I think the first thing that I would do with this patient is really spend a lot of time. I have the luxury of time, so I have an hour with new patients. I definitely would want a lot of history on her nutrition and what she's eating. More important than what she's eating, I'm actually really curious when she's eating and how she's eating. This couple things stick out to me. Obviously, the things that are. Let me just go one by one with what's underlined. She lost her job a year ago. Maybe it's significant. Maybe it's totally not significant. I definitely would hear her on that. I wonder whether she's feeling depressed. I wonder whether those feelings or an undiagnosed depression, change of life, is actually showing up in her gut in the way we've all been describing with the gut-brain interaction. So I'd be looking for that, but maybe I'm wrong. I kind of see how the story goes. For the past 6 months, the pain right in the middle, okay, epigastritis is kind of in the center. It's dull, it's throbbing. I definitely would spend a lot of time really questioning how related it was to food or not. Maybe she doesn't have pain immediately after she eats, but I wonder whether there's more subtle symptoms that she's having. I'm specifically very curious whether she's having bloating. The way I take a digestive history, I really like to hear about people's appetite, their hunger levels, if they're waking up hungry, if they're not hungry at certain times. I really like to hear about if they're having a problem with a specific meal or if it really is truly global. A couple things I'd be looking out for, um, whether she eats very late at night. I actually find that our metabolism actually slows down in the evening. Not every single person can't really eat at night, but I definitely find when people have a more sluggish metabolism, that could be playing a role. I definitely would be curious about how often she's moving her bowels. I see a couple patterns. One pattern I see is someone who has like a really weak stomach. They're really stressed out. They might have a lot of acidity. They might get bloated after their meals. So I would want to pay attention to those types of symptoms. Other people, it's kind of like it's a tube. You know what I mean? So if you're super constipated, everything's going to back up. So things might develop in that way. Um, Another thing I would look at too is if she's really eating mindfully. So they say we have 32 teeth, we should chew 32 times. So one bite of food, put the fork down. And this I've been really surprised with all of my patients with digestive health and myself. It really makes a big difference. How much you chew your food, if you eat slow, if you're present with your meals. So I would just be paying attention to a lot of those different things. It's obviously tricky when we run into these clinical situations where it ends up being functional. In a way, it's a good thing because we've ruled out a lot of nasty conditions that it could have been. Um, it's a little trickier to comment in general because I would really want to try to get in there and see if I could. I actually view this more of like a cluster of a bunch of other conditions that it probably could be, whether it's more mind body or whether it's kind of a more subtle digestive disturbance that's still in the early stages, so it hasn't progressed enough so that the inflammatory markers go up. So that's kind of my initial thoughts.
Awesome. Dr. Cohen, anything that you would add to that?
Yeah, the way I approach things is I like to think when I see a patient, and I tell them this, there's kind of three categories of things. Organics, there's something wrong with the organ. Motility, how things move or don't move, right? To move too fast, too slow. And functional, how you experience your digestive tract. And that's kind of like the three main categories you can kind of think of GI disorders. And someone coming to you with these symptoms, you can kind of put this patient's symptoms into one of those categories. So we do need to think about, I think there are a lot of functional overtones already. The life event of losing the job, the way they're describing the pain, the normal exam, but you also want to make sure that there's nothing organically wrong, right? So in my mind, I'm trying to think, is there something wrong in the stomach, like an ulcer? Is this bad reflux? Is the stomach not moving right? Or is it just how, or like how Zach kind of mentioned, is the patient just not eating effectively or for her tract, for her motility? Or is there something just functional, how they experience their digestion? So that's kind of how the wheels in my brain start to turn. And I usually want to make sure there are no warning signs or something we're really concerned about, that we have to rule out. And then using the Rome 4 criteria that we have that helps characterize functional GI disorders based upon their symptoms, we can feel more comfortable putting them there because you never want to miss something. But there are a lot of signals here in the history that are reassuring. So that's how I would approach it.
Awesome. Thank you so much. So, we got a question from the audience about actually what all of us have been talking about, which is um, can stress, anxiety, depression, and lack of sleep, can all those contribute to GERD or essentially symptoms of reflux, right? And, I think one thing to sort of hammer home this point again is that yes, all of those things can cause symptoms. That's why we have to take a comprehensive approach, as Dr. Cohen and Dr. Mulvihill had mentioned doing. But certainly, when people come to clinic, we're asking about those different stressors in life.
Can I just add?
Please.
Um, I agree with that, except for this presentation, we're talking about functional diseases. So yes, those things can exacerbate reflux, but in these diseases, we're talking about someone who has the symptoms, so maybe has heartburn, but when we test them every which way, they actually don't have reflux. So this lecture is just a little bit different than that question. I'm happy to talk about the
Oh,
variance.
yes, please. So our patient comes and, because of the difficulty with some sort of sensation, not quite difficulty swallowing, they end up getting this test. So maybe you could walk us through one, what this test is and sort of how you'd interpret it.
Sure. So when someone has difficulty swallowing, there are a few tests we can use to evaluate them. A nice sort of what I call a bird's eye view test is an old test called the barium esophagram. So in this test, you go to radiology, you stand in front of an X-ray, and you're given liquid barium, although we can give people a soft and solid barium as well. And while you drink it, while the patient drinks it, the radiologist will take a series of x-rays that, when played back, essentially look like a movie. And so it gives us a lot of information. It shows us the size of the esophagus, if it's narrowed somewhere, if there's a growth in the esophagus. But because it's a live video, it also tells us about movement. So as the person's drinking here, you can see the dark material go down into their esophagus. And we're looking, again, to make sure the esophagus is open, et cetera, but also is it moving down in a nice smooth pattern, which it is, or is it very slow? Does it get stuck somewhere? Does it stop somewhere? Does it go back and forth in the esophagus because the esophagus movement isn't coordinated? Does it go all the way through and then come back up, which is what reflux is? So barium gives us an idea of both the structure and the function of the esophagus. And here, this person's esophagus looks nice and normal in terms of size, and that barium seems to go down in a nice smooth pattern and clear down to a little bit beyond the point where we can see right there into the stomach.
Perfect.
And
And so
then,
the
oh,
twin sisters modified barium swallow. Uh, why don't you walk us through this too, Dr. Zumek?
right. So when someone has difficulty swallowing, there are actually two areas where it can be abnormal. So we think mostly about the esophageal part of swallowing. So you get the food into your esophagus, and for some reason, it doesn't go down normally. But before that point, the food has to get into your esophagus. And that's related to the movement of a bunch of muscles, your tongue and your throat, your epiglottis. It's actually quite a complicated set of movements. And those movements can go wrong as well. And that's a little bit outside of the gastroenterology GI tract. So when we think that that might be an issue, we send patients to either a speech and swallow therapist or an ear, nose, and throat doctor who does this similar idea, barium swallow, except the x-rays and images are geared more towards the mouth and the throat to look at that part of the swallowing. And again, this is a normal one where the person is able to get that food down into their esophagus without a problem.
Perfect. All right. And then because of the sensations that they were describing, Dr. Cohen, I'm wondering if you could walk through some of these images from endoscopy and sort of explain how you think endoscopy fits into this type of workup.
Sure. So endoscopy fits into her workup for two different reasons. One, the swallowing issue. So we want to look at her esophagus. And then the stomach, small bowel issue, the feeling full, the meal-related symptoms, the pain, feeling full quickly. So we want a structural look at the stomach as well, which was not shown in the esophagram. So this gives us a picture in time. And I tell patients this all the time. The endoscopy is not going to show the function necessarily. Do your reflux? How are things moving in and out? It's really to get a picture. What do things look like? And here we see normal. This is a nice looking esophagus. There's no inflammation. There's no bumps, lumps, nothing. So her swallowing symptoms fit between those two things, the three tests you showed, the barium, the modified barium, and this probably signal that the symptom of this feeling something up here and things moving down slowly is probably more functional than motility. It's how they're experiencing the act of swallowing. They're experiencing the movement of things up and down in the esophagus. So this is really building a reassuring picture for the case patient that you are presenting. And also, I'm just assuming, the stomach in this patient also normal. There's no ulcers, there's no inflammation, there's no irritation. The small bowel looks nice and full of villi. So all reassuring things, building the case to that this is a functional issue that we can create a toolbox for them to
Sure.
address.
Yeah, excellent. Thank you so much. And so circling back to our patient, as Dr. Cohen had uh, indicated, right, the upper endoscopy completely normal, and as Dr. Sumick had chatted about earlier, right, that means we looked at the esophagus, we looked at the stomach, and we looked at the first part of the small intestines. We ordered some labs. The labs all came back. These are blood tests, came back normal. And we test for this bacteria, H. pylori. And that came back as negative as well. And I'm wondering actually here, Dr. Cohen, if you don't mind, sort of elaborating like on what H. pylori is, right, and why I specifically called it out and how we test for it.
Sure. So H. pylori is the bacteria that finds itself its home in the stomach. And we don't know exactly where it lives in the environment, but we know it's picked up through the environment and it homes into the stomach. And for some people, the infection is asymptomatic. It's just there and causes no problems. But in a lot of cases, it causes symptoms because it causes inflammation. So the inflammation, whether it's just regular gastritis, just inflammation, or an ulcer, it can cause a lot of meal-related pain. It can also affect iron levels if the inflammations or ulcers bleeding, changes the acid level in the stomach so you don't absorb some nutrients like iron and B12. So it really can be multifaceted the way where it places itself in the stomach, but also the symptoms it causes. Long term, untreated can result in inflammation, ulcers, and unfortunately is a risk factor for gastric cancer. So that's why we do want to seek it out. And if it's there and you're symptomatic, treat it with courses of antibiotics and acid lowering medication. And for a good majority of people, that can take away the symptoms. And some people, despite addressing the H. pylori, the trauma of the infection leads to residual changes in how the gut nervous system functions. So it is part of the continuum and for some people in functional dyspepsia.
Perfect. Thank you. Okay. So we've spent a lot of time about talking what functional GI uh, diseases are not, right? They're not the structural stuff that we can see with endoscopy. They're not the tumor in your stomach. It's not H. pylori. We talked a little bit about this, gut-brain axis. And Dr. Cohen had sort of beautifully described, actually in three facets, how she sort of thinks about patients coming into our clinic. Um, but Dr. Mulvihill, I'm wondering if you could maybe elaborate a little bit more on sort of what the current consensus is essentially on where these issues overall come from.
Yeah, for sure. I would say that there's a lot of prevailing theories, but I wouldn't say there's one consensus. Like we're talking about, the science is still catching up. And I actually think we have a lot to learn from Eastern medicine specifically, because they have a lot of patterns, they have a lot of more subtle diagnosis. So a lot of times when I'm a little bit stumped with a more functional disorder, I tend to consider the prevailing theories, and then also if they fit a specific pattern for my additional training, that's like I was mentioning before. In terms of these three, altered gut-brain axis signaling, I think there's different ways to talk about that. One is definitely the fight or flight mode and the rest and digest. You have the sympathetic nervous system, which is your fight or flight. So you almost get by a bus, right? It's there because we used to have tigers to run away from. So you could fight, or you could flee. So you run away, right? You try to fight it, or you freeze up. And a lot of people do freeze when they stress. When you're stressed out and you're stuck in fight or flight mode, that actually affects your whole nervous system, and it affects your nervous system in your gut. It actually diverts blood flow to your muscles away from your stomach, because when you're fighting a tiger, you want to run away. You're not trying to digest your food. If you can do things like deep diaphragmatic breathing, learn how to meditate. There's so many different techniques, yoga, Tai Chi, Qigong, really going for a walk, different things to relax. Actually, what you can do is actually get yourself out of that fight or flight mode, which most people are really locked into, especially in New York, into the rest and digest. And naturally, we see people's motility get better. Their pain signals might go down. To tie it into this case, if that was the theory, right? Some people have this thing called visceral hypersensitivity. So the nerves in their gut are literally hypersensitive. Your nerves have like a little buffer on them. If they didn't have it, every time the wind blew, you'd feel intense pain. So there needs to be a threshold, but for some people that threshold becomes too low. So I might have bloating, and yeah, it's a little uncomfortable. For them, it actually might be painful. And I have lots of people I've treated for IBS and SIBO and lots of different conditions. A lot of times, a lot of their symptoms got better, and that was the one that lingered, was the pain. And it really didn't, not until we worked on the mind-body connection did that really change. So that's one big theory, and I always look at that. Abnormal GI motility. Yeah, it can be all different types of patterns. That's what I was wondering. Is this person globally slow, like she's super constipated and her stomach slow? Or is it more like a gastroparesis, like the stomach is really tight, but she's moving her bowels fine, so it's really upper? But certainly you can see all types of weird motility things, and I see it all over the place. So that's one way of thinking about it. Low-grade mucosal inflammation. This borders on the concept of leaky gut, which is still a little bit controversial. But it's definitely a prevailing theory, is that when you have altered gut microbiome, let's say you take too much antibiotics for something, you might lose a lot of the good bacteria and get too much of the bad. That might change your gut microbiome in a way that's pro-inflammatory. If that inflammation goes on for too long, that might weaken the lining, so that there's a little bit of toxins or inflammation can actually get into the bloodstream. So that's kind of the theory why a lot of like diseases could be like mainly digestive, but then all of a sudden have joint pain or be associated with other organs. So those are different ways of thinking about it. Um, but there's lots of ways.
Yeah, awesome. Thanks, Dr. Mulvihill. And we had a question come up in our Q&A about what role does inflammation play, right? And so just to be clear, right, when we are talking about like low-grade mucosal inflammation, this is inflammation actually that like we can't even find, right, on the end on the biopsies that we take now. So the question that had come from the audience was like, what role does chronic inflammation play in, any of these diseases and symptoms? And that type of question really is sort of beyond the scope of this webinar, because when we are seeing inflammation, that's when we are in the realm of organic disease. And organic disease can ex coexist and contribute to functional GI diseases, but really those types of discussions are a little bit beyond the scope of this lecture. But yes, long to answer it along a complicated question in a short way. Inflammation can be very important to the symptoms that people are experiencing, but is really not the realm of a functional GI issue. Okay, so um, w- we've had three amazing clinicians, right, walk us through how they would approach this patient, how they would interpret the diagnostic testing, right? And just to recap, right, we have a 63-year-old female. She's got upper abdominal pain, maybe some issues with feeling food go down her esophagus a little bit more acutely. She gets full easily, um, and she really can't have a complete meal. Um, she's up to date on her colonoscopy, and then all other testing, including, you know, imaging, like we went over, were negative, and endoscopy were negative, and she does not have H. pylori. So putting all of this together, Dr. Cohen and Dr. Sumek, how do you guys think about this patient's abdominal pain and sort of what diagnosis are you leaning towards?
Do you want to start, Dr. Cohen? Um,
All you, Dr. Sumek.
Okay. So I think more broadly, when a doctor sees a patient with any symptom, your brain just creates a long list of the diseases that can cause that symptom. And the last line of this slide is the most important because as the patient goes through their history, in our minds, that long list abdominal pain can be caused by 100 different things, right? But as the patient starts telling us details, we narrow that list and narrow that list and narrow that list. And then as we get past the history and do an exam and test, we narrow that list further until we get a diagnosis. Things that we think about as we're narrowing that list are uh, features of their history that would make us worried about something that's not functional. So something that's either inflammatory, infectious, or cancerous, like I was talking about in the beginning. So those would be things like weight loss, because in functional diseases, every part of your GI tract looks normal. You should not be losing weight. Fevers, which again signals an infection or an inflammation, um, true difficulty swallowing where something is getting stuck. So not the sensation of something abnormal, but food is actually getting stuck, bleeding somewhere, right? If everything's absolutely normal, there should be no blood coming out. So the first thing we want to do is make sure there's nothing that makes us worried that something else is going on. Because your GI tract deals with food and bowel movements, we always ask about the relationship to those two things, because if you have a symptom that has no relation to those two issues, it might not actually be coming from the GI tract at all, right? Because that's all that the GI tract does, deal with food and create stool. And external factors like medications always can affect the GI tract. And if someone has altered your anatomy, that can completely affect your GI tract in a variety of ways. So I think my point would be just how we think about things in terms of starting very, very broadly and then listening to the patient and then the exam and test and then narrowing it down. I'll let Dr. Cohen maybe talk about the specifics of this case.
Um, sure. I mean, Dr. Sumak and I trained together and we practice together, so I think we think very similarly, but it really is, it's like you have to put the puzzle pieces together, right? By taking a good history, the patient's gonna give you the puzzle pieces, and then together with, the physician and the patient will be able to put them together and get a picture. So the patient didn't really have warning signs. There is a relationship to food, not really to bowel movements, and they've had a negative workup. So that's where we really feel comfortable marching ourselves towards a diagnosis of functional dyspepsia. I will just say before we get into that about surgeries, the surgery can be any part of going into the abdomen. Surgery can be GI, it can be gynecological. People always think, well, I didn't have GI surgery. I still have my appendix, I still have my gallbladder, everything's intact. But the abdomen is an incredibly sensitive place. So just the cutting in, the ports, just the scalpel, that can change how the gut feels and functions. And often we underestimate those changes both at the abdominal wall level and then also internally into the abdomen. So history of surgery can really also help you understand what's going on. So this patient has, I think, given us the puzzle pieces we've put together, and we've come to a diagnosis of functional dyspepsia.
Amazing. Thank you both for walking through that beautifully. Um, a question from the audience did come in about asking us to define organic and functional, sort of what we mean when we use those terms. So just to clarify, right, organic disease is defined as a condition in which the symptoms are attributable to demonstrable structural, biochemical, or physiologic abnormalities that we are able to pick up on. They can be, these abnormalities can be picked up on imaging, laboratory tests, pathology. We have different modalities for that. Functional disease, and functional in medicine really, in contrast, refers to disorders where symptoms occur in the absence of identifiable structural or biochemical abnormalities, right? Essentially, we can't measure functional GI diseases in the same way that we could measure organic diseases, right? So, Dr. Cohen and Dr. Sumek, not surprisingly, absolutely nailed it. We have functional dyspepsia. And Dr. Cohen actually had beautifully talked a little bit about the Rome criteria, right? And so I'm hoping Dr. Cohen and then Dr. Mulvihill, if you could both sort of chat a little bit about the Rome criteria, what its role is here, why it's named after a city, et cetera, et cetera.
I think the Rome criteria is really important because it shows the shift from these disorders of brain-gut interaction being used to be seen as a diagnosis of exclusion to a diagnosis of inclusion. So it used to be you had to rule everything out first and then you can lie there. But we know that there are clinical criteria, which are symptoms based, that we can put patients into categories, and based upon data, we know that we can comfortably give a patient a diagnosis now. They don't need $1 million workup, 1,000 tests. We can do more targeted tests depending on their symptoms to make sure we're not missing something, motility or organic, and then feel very, very comfortable with this. Obviously, age is critical. You know, certain age groups we're a little more forward in doing a workup versus other ages, but in general, we can use these with confidence. I think that Rome came out of that they met in Rome. And it's gone through different iterations over the years. And as the data and the science gets more specific and understanding, they redo them every few years. So Rome 5 is coming out soon. And it spans basically esophagus to the colon and it subdivides based upon symptoms. And functional dyspepsia is one of the upper GI tracts. So it's about stomach and first part of the small bowel. And that's similar to what our patient has in terms of their symptoms, right? They have pain, they can have a burning pain, they can feel full. The fullness can be usually is meal related, but the pain can be with or without meals. So there's different subtypes of functional dyspepsia. And again, the patient's history is going to help you figure out which side they go on. In the end, we really target what the main symptoms are. And there's definitely overlap between, what we do, but the it's really about feeling your upper stomach. That's like the whole point. That's the whole concept of functional, right? You are feeling your digestive tract, how you and your brain and your gut and your food and the bacteria and the microbiome, it all interacts, and that's what you're feeling. And that's what I tell patients. And I think when they understand that pathophysiology, that's not all in their head. There is activity going on in their stomach and their small bowel. It really helps progress and, find a solution that works for them.
Awesome. And Dr. Mulvihill, maybe you could elaborate on that, specifically providing some context, because with your expertise in both Western and Eastern medicines.
Yeah, I mean, so my perspective, because I have the Western training along with functional and some Eastern training, I'm able to look at those simultaneously when I'm seeing the patient. So I'm kind of like to echo what we've been saying. I don't like the term diagnostic exclusion, but I'm doing that in my head to make sure that we're not missing something. Um, and to echo what we were saying before, what Dr. Cohen said, like I think a treatment-oriented, treatment-forward approach is the way to go. So if we reframe it, because a lot of times patients are disheartened, oh, we didn't find something, they didn't get a convincing diagnosis. But actually, it's a good thing. You found out you didn't have a lot of things that you really don't want to have. And also we have wiggle room to play around with different techniques, and we have some time. So I really also make sure that I'm validating the patient, that I'm really authentically listening to them. And I really am looking for the elephant in the room. Like why did this person get sick? What happened? What is it? Sometimes I actually really come up with a really convincing theory. Like, yeah, the diagnosis is functional dyspepsia, but it's just very particularized, the way we've been saying in terms of, but I am looking for things in their weighted balance in terms of what I really think is the main culprit, and then I take a stab at it. So if I think it's one thing, I want to push you that way. So if I think it's heartburn and actually they just didn't see the acid and I think it's something like that, I would give herbs that I find that are helpful for heartburn and teach some breathing techniques I think are helpful for heartburn. If it doesn't work, then I was wrong. If I was right, then that proves it. So that's kind of how I tend to navigate those things. And then I guess in the next slide we talk more about certain treatment things I tend to think about most.
Awesome. And so, as a perfect segue, Dr. Mulvihill and Dr. Cohen, um, I'm hoping you could walk us through this. So maybe, Dr. Cohen, you could talk a little bit about the different treatments you have, and then Dr. Mulvihill, you can add in, and we can sort of all specifically talk on neuromodulators as well. And Dr. Mulvihill, if you could, when you talk, if you could also address mindful eating, which was
Mhm.
raised as a question from our audience.
Sure. Okay. Well, do you want to go first? Or want me to go first?
I mean, I'll go first just for the
Yeah, why don't
broad
you go
point.
first? Yeah.
If there's H. pylori, we want to treat it, right? We want to treat H. pylori one because we talked about how it can cause inflammation, ulcers, it's a risk for gastric cancer. So if there's something organic here, there's an infection here, we want to treat it. What if that's there and we get it out of the way or it's never there, then the first steps for functional dyspepsia for this patient is lowering acid, not to treat inflammation because we know it's not there, but the acid lowering medications have twofold. One, some people are very sensitive to acid. The acid is irritating, and like Zach said, those nerves are on alert all the time, and they're going to be hyperreactive and hypersensitive to acid. So sometimes taking acid down in the stomach can help. We have two options, proton pump inhibitors and H2 blockers, and there are some data that they also talk to some of that low-level immune cells we are talking about. So not only can we lower acid, but sometimes we get some of the players out of the way so the stomach and the small bowel can calm down. Um, any treatment plan for a functional disorder is going to have some foundation in dietary interventions. There's some really strong data that that's where we need to start, especially given response rates for traditional pharmaceutical medicine. And dietary, I'll let Zach get into that more, but it can be what you eat, how you eat, when you eat, things like that. And then in terms of, after that, we're talking about mind-body work. So whether that's specific mind-body techniques, redirecting how the brain and the gut talk to each other, either through breathing techniques, talk therapy, yoga, meditation, acupuncture, and also low-dose antidepressants. We don't call them antidepressants, we don't call them anti-anxiety, we call them neuromodulators because we want to modulate, we want to change how that brain and those gut nerves are interacting and kind of reset them. And everyone's approach is very individualized. Their main symptom is different. The cause is usually different in people. People have different life experiences and events. So it's a really tailored approach for each patient. And for a lot of people, we are able to put a toolbox together that helps address symptoms. But it, like Zach said, it takes time. And we have to try and pivot. It's not straightforward, as in, you have strep throat, we're going to treat you with an antibiotic. It's much more nuanced.
Yeah, excellent. So yeah, to expand the diet thing, we just have a little blurb about her. I really would have wanted to hear when she wakes up, when she eats breakfast, eats lunch, dinner, or maybe she has a different schedule than that. Does she snack a lot? Is there specific meals she's getting into trouble with? The main way that it sounded to me was that she was getting this heavy feeling. So I'd be really curious, is she eating like foie gras? Is she eating heavy foods? Another thing is I find that people are not eating properly for their specific constitution. And this I won't go too much into. Eastern's really big on this, is not everyone should eat salads. If you eat kale and black beans, good luck. You're going to get bloated. That sounds healthy, but actually for someone that has visceral hypersensitivity, that might actually give them a lot of pain. So then I look for a lot of like common mistakes. A little controversial maybe. You're not supposed to drink a lot of water with your meals in Eastern. You don't want to overly fill the stomach, dilute your stomach acid too much. So I actually find that some people that might be it. So I really want to see what is happening in their meal times and how are they eating. In terms of mindful eating, the main thing about that is we have 32 teeth. We should chew 32 times. Do I chew my food 30 times? No. Do I count it? No. But I eat really slowly. I always try to put the fork down. I'm a stickler about my lunch break. I like my lunch break. I like to have my time to really digest my food. And I notice I don't digest my food as well if I don't have the time to eat slowly. It takes about 20 minutes for for the stomach to tell the brain that it's full. So you could eat a burger and fries and then feel really, heavy because it didn't have the time. Meanwhile, if you're eating something you have to chew more, it takes more time. So there's lots of good reasons to eat slowly and mindfully. So it's just one of these things I like to really see, and it usually jumps out at me if that's really the place to start. There's lots of other ideas in there. The low FODMAP thing usually is more on the case where someone has such bad bloating that we really think they have small intestinal bacterial overgrowth, and it's a whole different thing. But it means fermentable oligo, di, mono, different types of sugars that are mainly fructose oriented. It's a very random list of foods. Onions and garlics are very, very strong FODMAPs, but there's a whole bunch of them. So there's a whole plethora of dietary interventions that I would think about, but I would start with first with like how you chew in your food, when you eat your meals, the big ticket, and see if I could find like a really obvious culprit. Some people really don't do well with gluten, even if they don't have celiac. Some people don't do well with dairy, even if they don't have lactose intolerance. Things like that. So that's the main things I would start with. Um,
Awesome.
the only other main thing that I would say is there's so many different things I would try. Ginger really jumps out at me. When I just zoom out, okay, this person's digestion's weak. The analogy is, okay, if we made a campfire but we messed up, the fire was weak, we're all going to get sick because we didn't cook the food. What would you do? You put a log in it, you put the fire out. They can't eat too much. So you want to like give newspaper and blow on it, like kindle the fire. So we think of it as actually kindling your digestion. So that comes with sometimes people need to do a little bit more intermittent fasting, and we use supportive herbs like ginger, specifically if there's nausea. Um, there's things like digestive enzymes, there's digestive bitters that you spray in your tongue that actually stimulate salivation. Um, there's a million herbs that are super incredible and helpful for many digestive things. So I would have a lot, that would really be where I'd spend a lot of my time, tinkering with different herbs based on the pattern that I thought it was. And then if it works, then that proves it. If it's wrong, then I go in a different direction. Hope that makes sense.
Excuse me. That was wonderful, Dr. Mobhill. The two things that I think are just worth bear stating, right? As sort of a field, medicine, we've come to appreciate that the ways that we have advised patients in the past has sometimes been problematic about like diet approaches, right? So when we do dietary interventions, we do it very closely with our nutritionists and our nutrition teams because it is very easy and it's a slippery slope to eliminate things without true nutrition guidance. And that can lead to restrictive eating patterns, which is the last thing that we want to do, right? So it's always important to do these dietary interventions with your medical team, with a nutritionist, rather than try it sort of on your own. And then the second thing that I think bears sort of stating explicitly is like we've talked a lot about the mind-gut axis, right? The nervous system, the two sides of it, how there's as much serotonin in your gut as there is in your brain, right? Um, but it's also important to state that, like, people don't come to see us in clinic for like anxiety and depression, right? Uh, we're not well equipped to treat that, right? We use these medications, as Dr. Cohen really sort of astutely delineated, right? We use them to modulate the nervous system with respect to the GI tract. Okay. So that's why we don't call them antidepressants, and that's why we also are not equipped to treat those things. We oftentimes have to work very closely with people's psychiatrists and psych teams to make sure that we are not doing anything that they would disagree with, um, and work collaboratively as a team. But again, we our focus is on the GI tract and the nervous system and how it connects to that. Okay, so back to our patient. Initially, as Dr. Cohen had mentioned, we first approach is oftentimes acid suppression. So we started her on a proton pump inhibitor. Um, Symptoms resolved, but then a year later they came back. She came back to clinic, and this time we took another detailed history, and this time we chose to manage the patient with a neuromodulator. So I'm hoping Dr. Mulvihill and Dr. Cohen, you might be able to sort of elaborate a little bit on how you think of neuromodulation after the initial decision. Are you seeing these patients back frequently? How does that look for you?
So for me, it's the first part of this history is in the story. And I think is a part that's very, very frustrating for patients, and you touched upon in the beginning, is that it can come and go. This is a gut that's a primed pump, and sometimes it's in a good place, and then something can happen, it can go back. So there's a lot of ups and downs. So this pattern that they came back is not unusual and should, we should provide a lot of reassurance to patients that this is just the nature of it. The way I start neuromodulators when someone is open to it, I would never start unless someone's very understanding of the concept, is that we start at a very low dose and we're going to titrate up. We're going to find a level that they can tolerate the medication and they don't have too many side effects and it's starting to work. So I usually see people back within a month at the lowest dose and then increase if we feel comfortable. And then it's usually every 4 weeks until we find the dose that we want. And then we're going to cruise. I tell patients that this is not a short-term solution. Neuromodulation takes a long time. To retrain nerves, to regrow nerves, for nerves to recommunicate, it takes time. So I say this is going to be at least a 6 to 12 month. And then usually after that time period, the decision is made to continue or actually come off because the job has been done. And that's how I do it.
Wonderful. Yeah, and not much to add. I just think, she improves with the proton pump inhibitor. So, maybe the weak acid thing was part of it. So I might be paying close attention to things that I think might be triggering that when the recurrence came back. It's a typical pattern that I find, which is actually, I try to work with people really closely till, the problem they came to see me about gets better, or at least somewhere that's, really manageable. And then a lot of times I find that people actually feel better. But then she might have started doing some of the things. Might actually be a good thing. She started doing, eating pizza or something like that. And then so I'm just paying close attention and I'm always looking for the history. Like, well, what changed? The first time she lost her job, and now the second time something else happened. And then I wonder, maybe this is where you hold stress. Some people hold it in their shoulders, some people hold it in their hips. It might affect you more in your gut in that way. So I'd just be looking for that. In terms of the neuromodulator, yeah, I think it's cool. I think my role is usually to look at all the other things that I could help them out with along that lines, which really a lot of times is like yoga and breath work. Really, really some meditation, or at least meditate before your meals, and really, really lock in with the mindful eating thing. That's actually a form of meditation, so that's very patient specific, but I would kind of look for other ways or how that makes sense to them. Some people like to do a body scan and actually feel, oh wow, I actually have a lot of tension in my feet. It's not just actually in my belly, and they actually might notice other things. So I might direct them to mindfulness-based stress reduction. Our clinic offers a big, robust, evidence-based meditation and mindfulness intervention. So things like that is what I'd think about.
Perfect. And I'm wondering, could you specifically elaborate a little bit on traditional Chinese medicine,
Mhm.
acupuncture, and how that you might apply that to this patient? That was a question from our audience as
Oh,
well.
sure. It's my favorite thing. So acupuncture is actually just part of traditional Chinese medicine. It's not all of it, okay? And it's inherently more short term. There's a system of points in your body. There's 117 main points that correspond to your main organs. And other medical systems actually independently selected very similar points. And a lot of the research coming now is global, so it's all over the place. So it's becoming very standard. It's actually really becoming part of insurance coverage. Medicare actually will pay for acupuncture for low back pain because the evidence is so robust for that and it's expanding. So acupuncture is not just for back pain, actually, it's for almost any condition. It's just a different framework. I don't want to go too out there, but we talk more in the elements like earth and wind and fire. It sounds really wacky, but actually makes a lot of sense once you get used to it. And there's just certain patterns. So someone might have spleen chi deficiency, but actually their stomach's really weak, and they might get iron deficiency. They might have problems with malabsorption. It's just a pattern. Someone else might have more of a damp heat, and it's more lower, and then everything's blocked up. So we might focus on more on the, large intestine points. But the large intestine points are not on your large intestine. They can be anywhere in your body. So most times you'd be laying face down on your back very comfortably. It's actually very relaxing. If you've ever done yoga or gotten a nice massage where you kind of fall asleep at the end, usually it's like that. It's actually very enjoyable for most people. Very pleasant experience. So we have a very robust acupuncture service that's in the hospital. So it's a really nice setting for people. So I absolutely would be thinking about it for this patient for sure. I certainly, if it was feasible for her, would definitely recommend a few treatments, maybe come in once a week for a few treatments. I would just want to see if it worked as a trial. But more broadly, it totally comes to play because actually there's ways of asking patients questions and there's ways of taking their pulse and looking at their tongue. Actually, it's very fascinating to just do a different analysis, especially if you feel like you're at a dead end in your diagnostic tree otherwise. So it's super fascinating. I'm a big fan. I think you just have to be discerning. My only caution is where you're going for acupuncture, and that's a vetted place. It's not very dangerous, but things can happen. So you really do just want to, be careful about where you're getting access to that.
Awesome. Thank you so much for that. So as we wrap things up, Dr. Sumek, maybe you could elaborate a little bit of, what Dr. Cohen started as the discussion of, these issues being chronic, coming back, and it being a journey.
Yeah, I mean, I think both Dr. Cohen and Mulvihill sort of covered this really, really well. We're not talking about a pneumonia that gets treated with a course of antibiotics and it's over, right? You're talking about a GI tract where, although it's healthy, the day-to-day function, the sensation, the hormone levels, as you mentioned, the serotonin levels, um, vary throughout the day, throughout the weeks, throughout the months and years. And because of that mind-gut connection, your stress level and sleep level and anxiety and depression and all of that varies throughout the year. So it's chronic because it's not a one-time fixable thing. So it's going to be there to some extent going forward. And B, it's going to vary in severity. Now, sometimes people find a treatment or set of treatments that manages it permanently, right? They find their trigger, and once they know that trigger, they are able to use that treatment chronically. And although it's technically a chronic disorder, it's completely managed going forward. But we never get too worried when someone comes in and says, it was controlled for 6 months, it was controlled for a year or 2 years, and now my symptoms are back, and that's fine. We decide what treatment we're going to use for this flare. Maybe it's the same as last time. In this patient, a PPI worked last time, but we changed the treatment plan. So maybe it's a different treatment. But it's not an alarming thing for us when patients have flares of these functional disorders. It's actually quite normal.
Perfect. And so with that, I just wanted to thank, our panelists, Dr. Cohen, Dr. Mulvihill, Dr. Sumek, for really tremendous tour de force. And thank everyone for their questions. We're at the end of our time, and I just want to make sure to invite everyone to our next webinar, which will be on laryngopharyngeal reflux on September 30th.